Hi, I'm Dr. Jeff Yu, a board-certified ER doctor in both the USA and Canada, and today I'm going to be reviewing the Pitt Season 2, Episode 5. Let's get to it.
I took an early lunch break.
I don't know that you're going to make it back to work today.
About 4 hours ago, I gave her a dose of Keflex, told her to come back if things got worse.
Cephalexin, or Keflex, is the most commonly prescribed antibiotic for a cellulitis or a skin and soft tissue infection. It's definitely the standard of care. To see that the infection or the area of erythema or redness has spread way outside of that marked line within a 4-hour span is definitely a concerning feature for necrotizing fasciitis.
Jesse, can you get her started in trauma 2 with some Vanco and blood cultures, please?
Got it, boss.
Vanco is short form for vancomycin. It's a very strong antibiotic that we give through an IV for MRSA, or methicillin-resistant Staphylococcus aureus, which is a bacteria that is resistant to a lot of our common antibiotics. This is totally appropriate care for a rapidly progressive skin and soft tissue infection like this. Typically with necrotizing fasciitis, the things that we'd be looking for to point towards this diagnosis are, first of all, abnormal vital signs. That would be fever and low blood pressure and high heart rate, above heart rate of 100, pain out of proportion. So if the patient is wincing or screaming in pain with very light touch, also rapidly progressive or spreading redness outside of a marked line are all concerning features. The other thing that you can sometimes see is what we call skip lesions, where the infection spreads along the fascial planes, or like the connective tissue planes underneath the skin and the muscles, and then kind of erupts outside of that area. So it's like red, nothing, and then red again. Those are also very concerning features for necrotizing fasciitis.
Hanging Vanco.
What's Vanco?
A really strong antibiotic to kill skin germs.
Need a hand?
That's a good way to put it. Killing skin germs, that's exactly what it is.
She's not febrile, not tachycardic, no evidence of SIRS. Yet.
What's SIRS?
Systemic inflammatory response syndrome.
So SIRS, or the systemic inflammatory response syndrome, is 4 different criteria that we look for to point us in the direction of a life-threatening infection or sepsis. If you have 2 out of 4 of these criteria, this points towards a potentially life-threatening infection.
Please don't fire me.
This is Dr. Michael Rabinovich. I am the Chief of Emergency Medicine at PTMC. If you fire her, she will sue you, and I will testify on her behalf.
This is a power move by Dr. Robbie. It's awesome. Yeah, you know, like the thing that we commonly see in the ER is a lot of people asking for sick notes. This is quite frustrating for both patients and doctors, because a lot of workplaces don't believe people when they are really ill and can't come into work. So what we see in the ER is a lot of people who are sick with common like cold or flu-like symptoms that should be resting at home, but instead come to the ER, wait for like 2 to 4 hours just so that they could be seen to get a sick note to prove that they were ill. And I just think it's a terrible burden on the healthcare system that is absolutely unnecessary. In British Columbia, where I live, they just passed a law where workplaces are not allowed to ask employees for sick notes if they take up to 1 week of sick time off. However, when I speak with patients, they still say that a lot of workplaces are abusing this and threatening to fire people if they don't have a sick note. So we're still seeing a lot of people coming in for sick notes. It's really frustrating.
I am getting concerned. This is a millimeter past the line.
Or my line was sloppy.
Any increase in pain?
Oh.
Okay, sorry. Let's try.
So she clearly has pain out of proportion. This is quite concerning for necrotizing fasciitis.
Or morphine.
White count's only 10,000, it'd be over 12 for SIRS.
So he's saying that the white blood cell count, one of the SIRS criteria, is not significantly elevated. But again, there's 4 different criteria, and if you have 2 out of those 4, you know, that would still point towards sepsis or SIRS. You don't need all of those 4 criteria to be fulfilled.
There are other criteria.
Oh,
Still
there you go.
febrile.
Did you ask about past history of MRSA?
Not specifically, but she's never been hospitalized.
Any evidence of an immunocompromised state?
No, she's healthy.
Steroid use?
Never.
Okay, this redness is now a centimeter over that line, and this might be a bulla forming.
Vanco takes a
So bulla is a very concerning feature when you have a skin and soft tissue infection. It means that there's separation of your epidermis from your dermis.
I'm feeling a little warm.
That can happen with Vanco.
Thanks, man.
So I think what Langdon is doing is she's downplaying a lot of the symptoms and signs that they're finding on this physical exam. And that can be quite frustrating because it seems a little bit dismissive.
Lactic acid 4.2.
Okay.
What's wrong?
That can be a sign of a more serious infection, but the good news is we know what to do. Jesse.
So a lactate that's quite elevated at 4.2 points towards either end organ damage or cell death or muscle breakdown in this case. So this is a very clear presentation for now severe sepsis. Typically what we would be doing is giving her fluid resuscitation by giving her lots of IV fluids with a type of IV fluid called plasmolate is typically the most common one that we would give for sepsis. And we would broaden out her antibiotics. So on top of giving her vancomycin, we would add another bacteria like piperacillin tazobactam or meropenem. These are two antibiotics that are pretty much just like nukes for bacteria because they kill both aerobic and anaerobic bacteria in both the bloodstream and in the tissues.
This is severe sepsis.
I know, but at 7 a.m. it was a simple cellulitis. Anyone want to give her Keflex?
That is correct. He is totally correct that at 7 a.m. when he saw the patient with signs of cellulitis, any ER doctor would have given cephalexin. That is totally the standard of care. So he didn't necessarily do anything wrong during the first visit, but what he did wrong in the second visit is that he's dismissing a lot of her signs and symptoms and downplaying everything. And I think if I was Dr. Robbie, I'd be pretty annoyed with him.
We could add carbapenem or Zosyn and broaden our antibiotic coverage.
Okay, I got it. Thanks.
Yeah, I'd probably be
Jesse,
doing the same thing.
1 gram meropenem, 900 milligrams Clinda, page Dr. Garcia, please.
What else can I do?
I think you've done enough. You can go.
Apart from giving her broad spectrum antibiotics, which would be the highest priority thing to do for her right now, I would also be sending her for either a plain x-ray of her leg or a CT scan of her leg to look for gas-forming bacteria. Neck fash is what we call a clinical diagnosis. You don't need any imaging to confirm the diagnosis. However, it's an additional data point, and oftentimes if we're calling surgeons, like either orthopedic surgery or plastic surgery, to deal with this fast-spreading infection, they do want the imaging. So we usually just go ahead and do the imaging sooner than later.
That is a definite bulla. Did surgery come down yet?
Not yet.
I need surgery.
Page him again. Surgery would be a last resort. We would.
Yeah, so the bullae has already expanded from the first time that she was seen. So this is obviously very concerning. The first management in sepsis from this kind of thing is what we call source control. Sometimes patients with severe necrotizing fasciitis have to get their legs amputated. And the first time that I actually ever amputated a leg was when I saw necrotizing fasciitis in South Africa using a Geely saw, which is kind of like a wire saw that we use to saw off the femur a few inches above where the necrotizing fascia was. So absolutely wild stuff.
Shock, respiratory failure, and possible necrotizing fasciitis. She needs to go to the OR ASAP. The infection was isolated at the dorsum of the foot 5 hours ago, but now we're almost to the knee with bulla crevitis and edema. You seen neck fascia before?
In a textbook. I was a med student 2 weeks ago. Gotta show this to Dr. Garcia.
Okay, Jesus Christ. Go get anybody else from your service down here. Shamsi, Miller, Walsh.
I don't know any of those people,
Don't take
but-
this personally. I just need a fucking grown-up down here.
Yeah, necrotizing fasciitis is absolutely brutal. So that case that I saw in South Africa, we opened the skin, and as soon as we split open the skin, all the muscles were dark purple, and my attending took his finger to hook the muscle, and it literally just went straight through it like warm butter. And the way that we kind of dissected the skin is we just kept going up, 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 higher on the leg until the muscles look healthy and pink, and a few inches above where the diseased muscles were, that's where we essentially amputated the leg and sawed off the bone. It was absolutely wild.
Yeah, possible neck fash.
Possible.
Need CT with contrast to
This is
confirm.
spreading like wildfire. By the time you get your CT, it's going to be up to her waist. She's going to need a hemicorporectomy.
She needs a CT.
So this is what I was talking about earlier. Surgeons most often want the CT scan, so that's why I often do it up front, just to confirm the diagnosis and not delay things further. But again, if we're going by textbook, this is a clinical diagnosis. You should not need a CT scan to confirm that. And you shouldn't be delaying definitive care, which is essentially a leg amputation, to get that CT scan, because essentially the longer you wait to resect that tissue, the higher chance that the patient will die and lose more of her leg.
CT scan.
How about stainless steel scan?
For Christ's sake, Rabinovich. Robbie, what the fuck are you doing?
Oh, God, I think it might be.
That's called dirty dishwater exudate without purulence. There's a gray appearance to the fascia, and in the OR, you'll see easy separation of the tissue planes.
When do you start your sabbatical?
Tomorrow.
Not a moment too soon.
Thanks for.
Damn, that is a cowboy move. That is a cowboy move for him to cut into that tissue. Yeah, I wouldn't be doing that, but yeah, it's not technically wrong.
Hypoactive bowel sounds, soft with moderate tenderness in the left lower quadrant.
So hypoactive bowel sounds with tenderness in the left lower quadrant would typically point towards a presumptive diagnosis of diverticulitis. This is something that we commonly see in people that have chronic constipation and strain to poo. What happens is straining can actually increase the amount of pressure inside of your intestines, and then because of that increased pressure, you can get these like small little outpouchings called diverticuli. And because there's all these little diverticuli, the poo that kind of accumulates and sits inside these little pouches can become inflamed and infected, which causes an infection called diverticulitis. So if you have diverticulitis, that can actually cause an ileus or a stunning of your bowels. So the treatment for this would typically be oral antibiotics and kind of a soft diet with a lot of laxatives to treat the chronic constipation. This is something that we very commonly see in the ER almost every day.
Mrs. Randolph, do you take Percocet every day?
No.
Percocet is an opioid medication, and opioids actually cause further constipation.
Huh. And what about your water intake?
Pause. Mrs. Randolph, you said you don't take Percocet every.
Santos just cracks me up. Like, her bedside manner is just ridiculously bad, and the way that she teaches medical students is so condescending. If I was the attending observing her teaching skills, I would definitely take her to the side and kind of give her some guidance on how to provide better feedback and guidance for a medical student who's still learning how to take a proper history.
And they gave me this horrible drink.
Mag citrate.
Yeah.
Meg citrate or Citrameg is what we commonly refer to as dynamite for the bowels in the emergency department. What it does is it draws fluid into your bowels and also stimulates the bowels to move quite quickly. So usually within about 30 minutes, people will have like an explosive bowel movement, which can be quite uncomfortable.
Let's get you an x-ray and see how we can help you, Mrs. Randolph.
Thank you.
So an x-ray is probably quite appropriate for this presentation. X-rays should really only be done for two things in the abdominal region, and that's to screen for things like a bowel obstruction and to look for things like constipation. Apart from that, you don't get much detail for all the areas of your bowel.
Differential?
Differential is short for differential diagnosis. It's a short list of different diagnoses that we're considering, and in the top 3 to 5 diagnoses in our differential, we would actually investigate for all of them to rule in or rule out those diagnoses.
Probable stool impaction, but with her history of cholecystectomy, it could be small bowel obstruction.
Or worse?
Sigmoid volvulus?
Sigmoid volvulus is a twisting of the bowels with a closed loop obstruction. I mean, typically when we see sigmoid volvulus, patients look way more sick. Like they usually have fever, they have way more abdominal distension, and like way more tenderness when you feel their abdomen. So, you know, her presentation doesn't actually look very in keeping with that. She looks way too comfortable for a sigmoid volvulus, but definitely possible.
That's a surgical emergency. Wouldn't you have tons of pain?
Not always, especially when you're in your 80s.
No volvulus, no air fluid levels.
What do you think of this?
Fecal material?
Yeah, so that is what we would call a fecaloma, which is kind of like a play on words for like a mass, but essentially all it is a big ball of poo. Oftentimes we would also say FOS, or full of shit. So this is just like something that we commonly see, and this would require what we call a fecal disimpaction, where you go in with your finger and essentially just scoop out all the poo.
Shit ton. Sorry, I had to be said.
So what, she needs an enema?
No, tried and failed, remember?
Yeah.
Time to dig in.
I haven't done one before. Shouldn't I observe first?
I know just the guy to teach.
Mrs. Randolph, I would like you to relax like you're having a bowel movement.
So typically what we would be doing prior to disimpacting them is we would take a mask and take some flavored chapstick, put it on the inner lining of the mask so that you're breathing in kind of like cherry flavored chapstick instead of breathing all the fecal fumes.
And bring it out.
Yeah.
You're up, Ogilvy.
That's exactly how you do a fecal disimpaction.
Some more pressure,
And oftentimes
Mrs.
it
Randolph?
takes like 30, sometimes 45 minutes to do a full fecal disimpaction and to completely clear them out. Sometimes what
And
we'll do is
here,
we'll
I
combine
thought
that
you
with
weren't a quick
an
step.
enema. You'll like disimpact a bunch, use an enema, squirt it up to loosen things up again and scoop up more. So it's usually kind of like a back and forth.
Okay, Ogilvy, you might want to...
Oh, bro.
Much better.
Santos, you want in on trauma too?
Too much charting, too little time.
So Santos is trying to catch up on her charts. This is definitely appropriate. I know that Dr. Al-Hashimi is kind of painted as this hard-ass attending, but it is a big pet peeve of many physicians if a resident or other attendings aren't charting properly, because if a patient bounces back to the ER and there's no documents that you can refer back to, you have no idea what the thought process of the previous physician was, what therapies were initiated, what investigations were done or omitted, and what the thought process was behind that. So, you know, if I was Dr. Al-Hashimi, I would probably be hounding her as well to catch up on her charts.
Got a new one for you in third chain.
I'm 20 charts behind, and the new attending is threatening to make me repeat a year if I can't catch up.
Crimea River, old lady with bad abdominal pain.
20 charts behind is atrocious. I would absolutely be hounding her to catch up on her charts.
I consider the diagnosis of Cotta-Aquinas syndrome, but the motor...
How is she still charting on the exact same thing? It's crazy. Oh my God.
I'm feeling better. I'll just leave.
Mr. Diaz, even if your blood sugar is back to normal, we have to continue with the insulin drip until we clear the ketones from your bloodstream. Otherwise, you could experience electrolyte disorders, heart and kidney problems.
So she's correct. As I mentioned in my last video from the previous episode, someone with that bad of diabetic ketoacidosis, or DKA, would typically be admitted to a high acuity unit or even the ICU, so that we could be monitoring glucose levels and electrolytes every 1 to 2 hours. So for him wanting to leave against medical advice is very, very dangerous. And I think it's just one of the saddest things in American healthcare that a lot of people who don't have money or health insurance have to choose between going bankrupt or potentially dying. That's pretty dystopian to me.
Due to your family income, you make too much to be eligible for either Penny or the hospital's charity care.
But we can't afford health care premiums.
It's unfortunately very common for people to fall between the cracks.
That's crazy. Like, it seems crazy to me that someone can make too much money to not qualify for, I guess, like basic health care, and they just don't make enough money to actually cover the actual medical bills. Like, what happens to everyone in the middle class? That's wild.
3 times in one day. To what do we owe the pleasure?
I came down for a consult.
He's wearing hiking boots. That's quite common for an ER doctor too. That's pretty classic.
Gus Varney, 54, victim of assault with diffuse blunt trauma.
Deep whack through the muscle fascia. Can we get the cuffs off once he settles?
Not a chance. Orange jumpsuit, he's cuffed for a reason.
Let's go.
This is true. Like I've seen this many times, especially when I was working at Cook County, Chicago. People would be brought in orange jumpsuits and handcuffs, and the sheriffs are very, very reluctant to remove the handcuffs, even if they have really bad injuries. And they usually do that for the safety of the healthcare workers because a lot of these people tend to be quite violent or dangerous.
Oh, weird bruise. Did he fall on something?
Footprint. Got stomped.
Jesus.
Getting stomped in the right upper quadrant is brutal. Like I'd be really concerned about a liver laceration.
Okay, swollen mandible. Open your mouth for me, Gus.
The mandible is the jawbone. You know, often happens if you've been punched to the face or the jaw.
Yeah.
It's a great test for a mandible fracture.
Gus, bite down hard on this for me. Ah!
Yeah, so the tongue blade exam is getting someone to bite down on a tongue blade and seeing if they can actually resist pulling the tongue depressor out. If you have a fracture or a break to your mandible, oftentimes people will have excruciating pain and inability to actually hold the tongue blade in their teeth. The other thing that you would be looking for in a mandible fracture is to look for tooth malocclusion or asymmetry in the way that the teeth are connecting when you open and close your jaw like that.
Fractured left mandible, multiple rib fracture.
So the thing about a mandible fracture, he's saying that there's a left mandible fracture. Because the mandible is a ring-like structure, you don't often have a fracture in only one place. It's often broken in two separate places, or it's a fracture and a dislocation of your temporal mandibular joint on the other side.
When do pulmonary contusions peak?
After a few hours.
And do we always admit for a 3-rib fracture?
In the elderly, yes, but not if a patient can manage the pain and doesn't need supplemental oxygen.
Good.
Yeah, that's totally true. One of the more common misconceptions in the general public is that rib fractures need to be fixed with surgery and plates, but typically we don't do that because the evidence doesn't show that the outcomes are necessarily better if you have surgery to fix the bones. So most oftentimes patients will just get pain control with either IV opioids or oral opioids and sent home, and the bones heal over a course of 6 to 8 weeks. Sometimes if someone has very severe pain, we can do things like an epidural catheter in their spine or do something called a serratus anterior field block, which essentially injects a local anesthetic like lidocaine to dull the pain temporarily for about 2 to 3 hours.
Albumin's low, total protein's low. He also has megaloblastic anemia.
Malnutrition.
Probably jail cuisine. Whitaker, what labs should we ask?
Yeah, so megaloblastic anemia is a type of macrocytic anemia, which means that the cells that are red blood cells that are being produced are quite large. When someone has low blood cells, we often try to figure out what's causing the low blood cell count based on the size of the red blood cells. So a megaloblastic or macrocytic means that the cells are large. Normocytic is normal size, and then microcytic, which is the most common form of anemia, means that the cells are small, and that points more towards like iron deficiency is kind of the most common thing. But in a megaloblastic anemia, which is something that you don't commonly see in a first world country, oftentimes it's due to nutritional deficiencies.
B12, folate, iron levels.
Good.
New onset tonic-clonic seizure with right lower leg pain.
She hit it.
Tonic-clonic seizure is a generalized grand mal seizure where you have twitching behaviors, and then afterwards you have what we call a post-ictal state where you're kind of drowsy and confused. Someone that has lung cancer and has a seizure, I'd be very concerned for spreading of the cancer to their brain or metastases to their brain.
Initially nonverbal, now coming around.
That's normal after a seizure. Hi, I'm Dr. Al-Hashimi.
That is normal. That's what we call the post-ictal state. It usually lasts for about 30 minutes.
Give her 4 of Iron Versed for the seizure, 25 of Fem for the pain.
So Versed is midazolam. It's a fast-acting benzodiazepine. Midazolam or lorazepam are both short-acting benzodiazepines, and these are kind of the standard of care for a grand mal seizure.
Thank you. Nobody can ever get an IV in her.
Yeah, midline cath is the way to go when your veins are shot.
Yeah, midline catheter is a specialized IV catheter that goes into your upper arm. We insert this under IV guidance. This is quite common in patients that have chemotherapy because the chemotherapy essentially burns and destroys all of your veins. This is pretty typical.
Sorry.
You have kids? 2 boys, 15 and 9.
Yeah, cancer is an absolutely terrible disease, and it's just so sad when people are diagnosed with cancer at a young age. Well, at any age, but especially at a young age, especially if they have young families. It's brutal.
I'm Roxy's death doula.
Her what?
I help advocate for people like Roxy to make their transition to death a more peaceful process. It's like a birth doula, but for the end of life.
She's been a real lifesaver for our family.
Yeah, this is something that we're starting to see more commonly, especially in the palliative care world. It's important that we empower patients to have, to be able to make decisions and have appropriate care to allow them to pass as peacefully as possible with no pain or nausea or anything like that.
I have to pee.
Oh, there's no Purewick here, but here you go, hon. I'll help you get on.
No bedpan. I can walk to the bathroom. I just need a little help.
You sure?
Hey, babe.
Oh, we got this, Mr. Hemler.
You'll have to bring your IV and portable oxygen.
Please?
I'll grab a wheelchair.
Yeah, this is a pretty interesting point that they're including in the TV show. Kind of protecting and preserving a patient's dignity even at end of life and even if they're being palliated. Because I think the transition from being a quote-unquote normal human being to becoming a patient is a really, really hard transition. And whenever possible, we want to maintain normalcy, like allowing someone to at least pee or poo on a commode or go to the bathroom instead of lying down in a bed and having to urinate in a bedpan, which can be, a little bit humiliating for a patient.
Hey, Paul, why don't you come grab a cup of coffee with me? I'm still zonked from my all-nighter, and I want to go over some delivery instructions with you.
Sure. Rox, you okay?
She does a really good job of bringing the husband away so that, they're maintaining some kind of boundaries in, in like what's being shown. Because I don't think a patient ever wants their significant other or family members to see them at their worst.
We're from Glory about what's going on at Westbridge.
Radio silence from the ivory tower, and the charge nurse over there isn't responded.
Must be bad. I wonder if it's something that security needs to know about.
I'll keep you posted.
Hey,
Yeah, I think given that it's July 4th and there's a code black, I wonder if there's like something to do with fireworks or a bomb threat or a mysterious package. That's what I probably would have put my bet on.
Hold out your hand, Louis. A little shaky.
No surprise. I've been here since 4 a.m.
So he's got a resting hand tremor, which would point towards alcohol withdrawal. So I think I mentioned this in the previous video, but what I would have done much earlier, like when he is initially presented with his ascites, I would have started what we call a CIWA protocol, which is the Clinical Institutes of Withdrawal of Alcohol, which is a scoring system to determine how severe your alcohol withdrawal is. And we match the dosage of medications like Valium or diazepam to treat the symptoms of withdrawal so that they don't have something like a seizure and become critically ill while under the care for other issues.
Oh, I can take care of myself if you cut me loose right now.
Let's get Louis 50 milligrams of Librium.
I'll put in the order.
So Librium is in the same class as Valium or diazepam. It's a long-acting benzodiazepine. We don't typically give Librium in Canada, so this is maybe like a more USA-specific management, but the management is essentially the same with a long-acting benzodiazepine.
Louis! He kept pulling off his pulse ox.
It's on. It's at 71.
Louis, wake up!
I'm gonna get the carotid.
I got the airway.
Hey, Perla, crash cart intubation tray, please.
Why aren't they starting CPR, man? There you go. Bro. All right, so that's it for season 2, episode 5. Overall, I thought it was a really good episode. They touched on some of the tension and dynamics between the hospital service and the necrotizing fasciitis case. And I thought that they did a pretty fair representation of like the frustrations that we feel as ER doctors when we feel like surgical or subspecialty services are not responding to our calls quickly enough or delaying what we believe are necessary care to, save a patient's life. They also touched on issues related to affordable care, which in that DKA case, which I think is just overall quite sad as a Canadian kind of looking at US healthcare from an outsider's perspective. And they also touched on some of the human factors in terms of like maintaining dignity during both sickness and during death in the case of the patient with cancer. So I am really excited to see what the next episodes hold, like what happens with that code black at that other hospital, and also what happens with our patient with alcoholic liver cirrhosis. If you thought this was helpful, informative, or entertaining, please give this video a like and subscribe to the channel so that we can feed this algorithm and bump this channel up. And I'll see you in the next one.